Maisha ni hell. Maisha ni hell.
The Kenya government in 2018 prioritized universal health coverage, or better known as UHC, as part of its key agenda items, the main view being ensuring access as well as affordable and quality health services at both the national and county levels. This is Maisha ni Health, a series of TV programs where we highlight the achievements and progress of UHC in some of the areas where it has been rolled out. We do this by bringing you the beneficiaries as well as the key players behind this great undertaking. Now, today's edition takes us to the great county of Nyeri, where we examine the role of the National Health Insurance Fund in the rollout of UHC, as well as taking a look at the managed equipment service. As always, my colleague Mutala Mukosia is on the ground. Let's go straight to him.
Today we are at Nyeri County, meeting the people and seeking their views on public healthcare system. Let's see what you got today. Mimi naitwa Mutala Mukosia. Wewe unaitwa nani?
Mimi naitwa Genesis.
Yes.
Kutoka hapa upande wa Nyeri.
Sasa nilikuwa nauliza kuhusu mambo ya public healthcare system. Kumekuwa katika hospitali zetu kuna mambo ambayo serikali ilileta ya dialysis, kuna mashine nyingi ambazo za kusaidia katika mambo ya kansa na mashine nyingi za kuwezesha shughuli za afya. Hizi shughuli sasa hizi unaweza zipata hapa Nyeri. Si lazima uende Nairobi ama uende nchi zingine. Ukiangalia na miaka za nyuma ambazo hizi mashine zilikuwepo, unaweza semaje?
Mashine zile ziko raundi hii zinaangalia mwili wa mtu, ugonjwa mahali iko. Ni mashine za hali ya juu, unakuta inapima mtu kama ni kansa, ina reflect mahali ugonjwa hiyo iko.
Before iko diagnosed, ilikuwa ina take time, but right now ukienda hosi unaambiwa you have signs of certain disease like cancer, immediately unafanywa MRI because they are readily available.
Kaa kitambo kulikuwa na venye watu walikuwa na shughulikiwa na unaona kaa watu wana fundraising hivi wafanywe matibabu, lakini saa hii government imesaidia na hizi NHIF zinasimamia mambo kaa hizo.
Watu walikuwa naenda bari, time yako bado pia unatumia muda wako mrefu na masaa yako mingi ukifanya hizo shughuli, lakini saa hii ziko karibu, kwa hivyo tuko sawa.
Nashukuru sana. Haya basi mtazamaji, hiyo ni mitazamo ya watu tofauti tofauti katika kaunti ya Nyeri, wakiwa na mitazamo kuhusiana na swala hili zima la afya na kuletwa katika hizi hospitali zetu kuanzia kote nchini. Tukisema hivyo hapa Nyeri ambapo tukusikia leo, unaona kuna kuwa na mitazamo, watu wana mitazamo tofauti tofauti, yapi ambayo wameweza kufaidika na yapi ambayo wanafaa, yani serikali inafaa kuwezesha hata zaidi. Mimi naitwa Mutala Mukosia, tukiwa maeneo ya Nyeri, na kumbuka wa show ni Maisha ni Health.
Maisha ni health. Maisha ni health.
Maisha ndio afya.
Maisha ni health.
For many years, dialysis has been a challenge to Kenyans. We are talking about people getting these services only at Kenyatta National Hospital, sometimes out of the country. But today, we are talking about these services being brought closer to Mwananchi. And today, I am at Gatito in Nyeri County, and I'm joined by Mr. Simon Theuri as we hear his journey. Remember, this is Maisha ni Health.
My name is Padri Simon Theuri from Gatito sub-location in Nyeri Central. I've been a victim of prostate cancer from 2016, and because of the medicine that I was taking due to the prostate cancer, I then started to have failure with the kidneys, and therefore I had to start dialysis. So in Kenyatta, I started the dialysis, hemodialysis, and from there, since the government had opened other branches, like Nyeri PGH, so I continued with the dialysis to date. I've been having dialysis in Nyeri Central. I have been assisted by NHIF as far as sponsorship is concerned. Comment on those who have not joined the NHIF to at least try and join the insuring body, because it is of assistance as far as medication, as far as treatment is concerned. So those who have reached the age, at least to see that they join. When they join, they also help to improve NHIF as a body, as an insuring body, as far as sickness is concerned. Before UHC took over, there had been problem of medication in hospitals, and especially a big hospital like the PGH in Nyeri. It has improved because, one, there is medication, the manpower concerned, the nurses, the clinicians, they are supplied by the doctor and by the government, and they are doing good work.
Maisha ni health.
For many decades since independence, there was only one referral hospital in the country. Kenyatta National Hospital was the only facility with specialized equipment to handle chronic illnesses. All too often, Kenyans lost their lives that could otherwise have been saved because these services were located far away at Kenyatta National Hospital in Nairobi. Many could not afford to finance the frequent trips required for weekly dialysis, for example. As a result, many could give up and face their fate. Even those who could make the frequent trips found long queues of other Kenyans needing the same service, leading to the same result because illness does not wait. Today, however, the situation is vastly different. The government, seeking to bring quality medical services closer to the people, has ensured that modern equipment and qualified personnel are availed in every county to serve Kenyans.
Through the Managed Equipment Service project, my administration has supplied 1,241 pieces of specialized medical equipment, with 113 hospitals being equipped in 47 counties at a cost of Kenya shillings 43 billion.
This array of equipment covers a wide range of medical needs, from dialysis, surgical, radiology imaging, orthopedic to oncology treatment. What about qualified medical professionals to operate this equipment and manage the treatment protocols?
Honorable members, regarding medical training, the number of Kenya medical training college campuses has increased from 28 campuses in 2013 to 71 campuses today.
To achieve universal health coverage, there are many components that are needed to work together seamlessly. The MES program, coupled with qualified medical personnel, is a key component without which the aspiration to Medicare for all Kenyans would flounder. It is also imperative that the equipment is at par with the global standards, and the training curriculum for medical personnel meets the same high standard.
We are currently training 7 programs, and we are planning to increase the programs to be able to meet the demand of the community. The programs that we are training are geared towards delivering that component of universal health coverage. The examples of the trainings that we offer here include nursing, and it is called community health nursing. Number 2, clinical medicine. Clinical medicine normally offer clinical work. Then number 3, we have pharmacy. Pharmacy students are being trained to be able to dispense drugs. Medical imaging science, that's number 4. Students who are being trained to be able to handle X-ray machines, to be able to handle MRI machines, CT scan machines. So in universal health coverage, that component is key, and you realize that even the government gave equipment to hospitals. Medical laboratory sciences, students who are trained on medical laboratory sciences are the ones who will go to the laboratory. We imagine of a bacteria, of a virus, we imagine of a parasite, but these students are trained to see them. we have introduced a new program, that's the 7th one, called Emergency Medical Technician course. You've realized in our community setup, accidents may occur. And the people who address those accidents, the people who will help the victims, are people who are not trained. So now we have emergency medical technicians who will be able to respond to any emergency. One of the things we are doing in the training of these health workers, most of it is practical. A larger percentage of it is practical. So we give them theory, and then they go and practice. They do a practical component. Right now, for the practical part, we purely use a skills lab, and we have this state-of-the-art equipment for skills lab demonstrations. We have a spacious skills lab for that purpose. KMTC Nyeri is one of the many campuses of KMTC. There are close to 75 campuses now, training almost similar programs, but diverse.
All the 47 counties are beneficiaries of the Managed Equipment Service, meaning that Kenyans in all parts of the country can access medical services that they hitherto had to travel long distances to access. Can Kenyans afford to pay to use this equipment?
At Ewasonyiro Sub-County, Nyeri County, we meet Mr. Paul Waiguru, who is going to share with us his journey with dialysis. Remember, this is Maisha Health Program. My name is Mtala Mkosia. Karibu sana Bwana Paul katika kipindi.
Mzuri sana.
Tunashukuru sana kutukaribisha kwako.
Hapa ndio nyumbani.
Asante sana. Ningependa utueleze safari yako na jinsi ugonjwa ulianza hadi umejipata katika hii safari. Hii safari ama hii sehemu ambayo uko sasa hivi.
Hii ugonjwa ilinianza mwaka wa 2021 mwezi wa 11. Na ndivyo nilienda hospitali hizi hapa karibuni. Karibu mpaka kasemekana nikatumwa Nyeri kwa General Hospital. Kwenda huko ndiye nilienda nikavimwa, nikawekwa vipimo mpaka ugonjwa ikaonekana niko na kidney yangu haifanyi kazi. Sasa ndiye nikalazwa General Hospital mwezi wa 11, nikalazwa wiki 3, ndiye nikapewa ruhusa sasa nikakuja nyumbani. Lakini wakati huo ndiye nilianza tu mambo ya dialysis. Kusema ukweli, mimi nimesaidiwa sana na hii kadi ya NHIF. Sababu hiyo pesa mimi sigi afford. Havana hiyo vipimo ya mapisha, vipimo, madawa, kulazwa hospitali, hiyo yote singeweza. Lakini mimi nimashukuru Mungu, hiyo kadi imenisaidia sana.
Asante sana Bwana Paul.
Hata mimi nimeshukuru sana kwa vile mmenitembelea.
Asante, nashukuru.
Nimeshukuru.
So that has been the story of Mr. Paul Waiguru from Ewasonyiro Sub-County here in Nyeri, and this is Maisha Health Program. My name is Mtala Mkosia.
Now from the great county of Nyeri, county number 019. This is my pleasure to introduce you to this segment of the show. Remember, our show is Maisha Health, a continuing series highlighting the progress and achievements made in the universal health coverage as envisioned in the Kenya government's Big Four agenda. Now, for this particular segment, we're going to have a live panel discussion with the big players undertaking this major rollout of UHC, and we also have a live audience with us. Karibuni sana and welcome. Allow me now to introduce to you my panelists this evening, and allow me to start with the lady, Dr. Isabella Maina, Head Department of Healthcare Financing at the Ministry of Health. Of course, the ministry is the main backbone of this rollout of universal health coverage. Next to Dr. Isabella Maina, on her left is Thomas Mwangi. He's in charge of the COVID ICU at the Nyeri Referral Hospital, and will be telling us more about the managed equipment services at the hospital. He's also the chair of the National Nurses Association of Kenya. Last but not least, on my immediate left, we have Dr. Peter Kamunyo. He is the Chief Executive Officer, National Health Insurance Fund. Now let's go straight to the questions, and I'll start with you, Dr. Kamunyo. Now we talk about healthcare financing and universal health coverage, and some of these things may sound a bit foreign to the layman. Now, simply just break it down to us.
What is this universal health coverage? It simply means that everyone has access to the healthcare that they need, to the quality healthcare that they need, without suffering financial hardship. It does not mean it is free. It does not mean it is a scheme. It just means that everywhere where they are, they can be able to access quality healthcare that they need without suffering financial hardship, without becoming poor, without becoming impoverished.
Now, for us to get UHC, it means we must invest. We must invest in human resource, we must invest in equipment, we must invest in hospitals, we must have the financing. So where NHIF comes in is to ensure we have adequate financing for UHC. It is to ensure that Kenyans are protected from being poor as they seek medical services. So if you think of NHIF as a basket, or if you think of the chamas, the merry-go-rounds that women have, so NHIF, Kenyans will contribute into that basket, slowly by slowly, small amounts of money every month. For now, it's about 500 per month, per household. And remember, a household has several people, about 6,000 per year. So you contribute slowly by slowly, so that we pool together, we pool the risk, so that should one feel or have the need to get health services, should they fall ill, then they'll go to that basket, they get services from the hospital, and then NHIF will pay. So how is that Kenyan protected? It's because we have pooled these resources, just like the chama, the women pool, then they buy for you a jiko, so you don't have to go to the, to the supermarket and pay 1,000. You pooled maybe 20 bob every week, then the jiko costs 1,000. So at that time, you don't need to remove the 1,000 from your pocket. So at the time of accessing the services, NHIF will pay for you. And we shall be seeing the services later on.
Let's bring in Thomas Mwangi into this conversation. Now, one of the issues that have many patients, many people, especially in a county like Nyeri, which is a majority of the population can be considered a rural population, is access to health, access to the kind of equipment that's needed. Now, one of the pillars of towards achieving universal healthcare is a provision of medical equipment, and there's that service called the Managed Equipment Services. You are in charge of the COVID ICU, and with COVID we saw the extent of the need of some of this equipment. Would you say, from your standpoint, that there is an improvement in as far as access to medical equipment in Nyeri is concerned?
Thank you, Fred, for giving this opportunity, and welcome to County 019. I would like to say that the Nyeri people have really benefited from this MES program because initially the number of ICU beds were quite few. I think we had only 2 ICU beds with 1 ventilator. As we speak, we have a COVID ICU and a general ICU. The COVID ICU, we have 3 beds, all of them with ventilators and backup ventilators, just in case of something. Over and above that, the general ICU has 6 beds, with all of them with ventilators, both for children and adults, and even neonates. Neonates are children below the age of 3 months. Over and above that, the benefit has been tremendous, and we have seen that even other counties, not only the county of Nyeri, have been benefiting from these equipments, because we've had people coming as far as, patients coming as far as Marsabit to come and access these facilities.
Okay. Can we say that probably this is a direct result of Nyeri County being among the first beneficiaries of this UHC rollout, because you're the first of 4 counties to benefit from this?
Very true, because as you can tell, the rollout of UHC has really uplifted the lives of the Nyerians. Over and above that, the continued access of quality healthcare has been entrenched in our systems. So all of the Nyeri people benefit, and even the surrounding counties.
Now let's come back and talk more about NHIF, Dr. Kamunyo. Now, how many Kenyans have benefited from the revamped NHIF plan, and what are some of the benefits of having an NHIF cover?
The short answer to that is that every Kenyan can benefit, and every Kenyan has benefited. Traditionally, people knew NHIF ni ile bima inalipia kitanda peke yake. And that changed from 2015 when we introduced expanded covers and packages that you're asking. That's the time when we introduced outpatient, which now you can access very close to you. That's when we introduced packages like dialysis package, kidney transplant package, oncology or cancer package, radiology package where you can get the MRIs that you're now, CT scans, etc. So in 2015, we can say is the first time that we transformed in this journey towards UHC. If you are contributing 500 shillings a month or 17 shillings a day, and should something happen, we can pay for you even $500,000, we pay for you 180,000 for surgery. You see, that is a big difference between what you've paid and what we're paying out. So to make sure that it is sustainable, we had to undergo the reforms. To get to universal health coverage, there are 3 things that must happen. One is the economic empowerment. But we know that not all of us can be at the same level. So what can give us that equalization? Risk transfer or insurance. So everybody pays 17 shillings a day or 6,000 shillings a year, and you have access to state-of-the-art treatment. The other one is ensuring that the benefits are present. And Dr. Isabella also mentioned the accessibility and the quality of the same. And then finally is that everyone is on board so that no one is left behind. The spirit of UHC is that everybody who can pay, pays, and those who cannot pay are identified and supported.
Patients who have NHIF, they're benefiting greatly, because as you can imagine, a day spent in an ICU is very expensive. But a patient who has NHIF, they are covered for every single service provided.
So where are we now? If at all the journey is, let's say, 100 kilometers long, how far are we towards achieving universal health coverage?
Okay, so thank you very much, and I'm glad that you have said UHC is a journey, not a destination. And I think our CEO, NHIF, said that we started, way back at independence, where Kenyans were paying maybe 5 shillings. They were not able to afford, and then that was removed, free services, and back and forth, back and forth. And from 2013, that's when we've been on the real journey towards UHC. And some of the programs that are showing us where we are, which were initiated, for example, in 2013, is the insurance subsidy to the elderly. We are right now covering over 253,000 persons, orphans, and vulnerable children household. We are covering about 53,000 elderly households. We have Linda Mama program that allows access to free maternity services and postnatal care, antenatal care for mothers, and services for children up to 1 year. And that has helped about 1.2 million mothers. But then coming to 2017 is where there was acceleration of UHC, where we started with the pilot. We had the pilot in the 4 counties, and then scale up, meaning that Kenyans now can access health facilities. If you look at, for example, equipment, we now have about 42 MRIs in the country. That is magnetic resonance imaging. It is a more advanced X-ray form of imaging. We have 42 up from 20 in 2013. We have X-rays about 41 up from 41 to 255. The theaters, we have built about 116 more theaters in the period, meaning there's more access to specialized services.
I can resonate with what Dr. is talking here. Over time, healthcare is a system. Healthcare is about not only the infrastructure, it is also the human resource. Over time, more and more people are specializing in different areas. We're having consultants for different conditions, different departments, and this has been growing more and more. And even as we speak, Nyeri has quite a number of doctors who are already in school, continuing, and we're having more consultants already coming onto the pool.
Now, compare the availability and quality of medical personnel and equipment today compared to, let's give it 8 or 10 years ago.
It is so evident. It is being felt on the ground because some of these things were unheard of, even when us guys were in school.
So we've seen the changes in what we call the investments in health, the health facilities, the equipment, the commodities availability. So those are supposed then to lead to better health outcomes. So what we have seen, for example, if I look at antenatal care attendance, previously by 2013, if you take 10 mothers, only 4 were attending antenatal care. But because of Linda Mama, which is part of UHC, about 8 of them are now attending antenatal care. That helps in preventing any maternal complications when a mother is pregnant. If you look at deliveries, the same trend. And we want Kenyans to be healthy, to be able to participate in productivity for the nation. Thank you very much.
Thank you so much, Dr. Maina and all my panelists. After this, we're going to be fielding questions from our audience here. We do have beneficiaries of UHC. We do have medical students in our audience, and they'll be asking our panelists those pertinent questions. Don't go too far.
Asante sana Fred. Kwa hivyo tunaenda katika hadhira ambayo tunataka kuzungumza nao kuhusu maswali gani ambayo uko nao kwa wageni wetu.
I'm a beneficiary of UHC and NHIF from prostate cancer. And these 2 departments have really done good as far as we as patients are concerned. But what I would like to ask is whether the 2 bodies can see as far as provision of health technicians are there as far as the dialysis is concerned, because the ones that we have seem to be stretched. What is NHIF doing as far as this field is concerned? Thank you.
So for us to ensure that they are technicians is to ensure that we pay regularly and our turnaround time after you've gotten your service is given in good time. So with the reimbursement and making sure that it is fair and making sure that it is paid on time, then the facilities will be able to use that money to ensure that the service is available and the technicians are present.
For me to enjoy UHC, must I be a contributor of NHIF? Thank you.
That is a very interesting question because when we go back to the definition of UHC, is everyone has access to healthcare they need without suffering financial hardship. So if you have enough money in your pocket that you can go and seek services from any hospital, whatever the cost, you're actually experiencing your UHC because you're not going into financial hardship. But do we have that money to be able to pay for healthcare anytime, anywhere. No, we don't. And we've also seen even people of very high means struggling with a hospital bill because when it comes, you're not prepared, you don't know what it is, and you don't know the extent. So, NHIF, in that model of financing called output-based model or insurance model, is you transfer your risk. So as opposed to you carrying the risk in your pocket, is that once you pay the premium, you join this big group so that your healthcare can be paid for when you go to hospital. So it is a way of socially protecting you. And that is why it is the model that the government is using to scale up for UHC, so that everybody now can have that access.
Naitwa Jackson Thega, operator wa bodaboda. Swali langu ni kwa hii industry yetu huwa tunapatana na ajali sana sana na unavunjika to an extent unaambiwa utawekwa hadi chuma. So nilikuwa nauliza NHIF ni aje inaweza saidia kwa hizo chuma juu most of the time it's very expensive. Unapata inasimamia kutengenezwa but chuma unajishughulikia mwenyewe. Asante.
Kwanza hilo ni jambo la kwanza tu na unaona serikali inahimiza ya kwamba hata watu wa bodaboda wajitahidi wawe members wa NHIF. Lakini kujibu swali lako, kwenye packages za NHIF, hiyo chuma huwa ni covered. Ya kwa sababu ni hiyo package yote. Lakini unaweza pata kuna wakati hiyo chuma inakosekana kwenye hiyo hospitali. Ndio mnaambiwa nende mkanunue ama kitu kama hicho. Nafikiri ndio inakuwa.
Kwanza ni kwa daktari wetu wa Nyeri. Si watu wa Nyeri kama sisi na viongozi. Tukitaka kujua kwa hii PGH kuna mashini ngapi na ni za aina gani. Kwa sababu tukiwa nje na tujui kuna mashine aina gani, itatufanya pengine tuende Nairobi tukatafuta hiyo mashine na pengine tumia medical equipment tunatumezea cha Nyeri.
I can enumerate them. We can start with the CT scan. There's a CT scan that is functional. Not only functional, it has a consultant radiologist also manning it. There is an MRI. That is magnetic resonance imaging. Any diagnosis that is not been seen on a CT scan inafanywa na MRI. There is an X-ray machine which is also functional, and there is a dental X-ray. There are two ultrasound machines in the X-ray department. Also, when you go to the ICU, there is both the COVID ICU and the general ICU. Tuko na vitu zinaitwa cardiac monitors. We have 4 of them. When you go to the main ICU, there are 10 adult ventilators. 10 of them, very advanced. And then we have 4 pediatric. Pediatric ni ventilator ya mtoto. Then kuna 2 neonatal. Then we have 6 automated ICU mattress beds with Ripple mattresses. We have 6 cardiac monitors. Hiyo ni wakati mgonjwa mnasikianga kitu inalia titi na mnaona maandishi pale. We have 6 of them, and then we have 4 cardiac monitors za transport. Wakati unataka kupeleka mgonjwa mahali, kuna yenye unaweza beba. Yes. Thank you very much.
Asante sana, hizo equipment ni nyingi sana.
All this investment that you're asking Kenyans to all contribute to building the healthcare system, how do you make sure that counties also invest in the parts that they need to invest in?
The national government is working with the counties to sort of ring fence the funds for health, especially at the health facility level, so that whatever you get from NHIF, for example, is used and invested within the health facility, so that you are able to pay your health workers, you are able to buy more equipment, you are able to get more medicine, and address any shortage that you may have. So thank you very much. Okay.
Niko na swali moja kuhusu community strategy. tunajua ya kwamba prevention inafanyika pale chini katika level 1 ambayo ni community pale mashinani. Sisi kama madaktari mashinani tungependa tuulize ofisi ya NHIF, je, NHIF iko na mpango gani kuhusu community unit?
Okay, so thank you very much. Indeed, yes, as I said, there's a lot of focus on community level services because of what we said earlier, prevention. So, and I started by saying we already have community units set up within the country. We have over 90,000 community health workers. So the support, especially from the national level, is through trainings, sensitization, developing the modules, the necessary modules to keep updating these community health workers, and also ensuring them that they have the necessary kits. However, we also have, the county government's role to be able to support the community health workers, especially through, something small to encourage them to do the work, and ensuring also that they have the relevant, equipment, the basic equipment, basically like the thermometers and all, to be able to do their work.
Wow. Thank you very much, my panelists and dear audience, for such an engaging talk, and for this a round of applause, tafadhali. Thank you so much, my panelists, Thomas Mwangi, Dr. Isabella Maina, and Dr. Peter Kamunyo, CEO, NHIF, for helping us understand exactly where we are in as far as the universal health coverage is concerned. Now, on the role of NHIF and MES in as far as UHC rollout is concerned, this is what Cabinet Secretary, Ministry of Health, had to say about it.
Conversations on UHC from participants in my home country of Nyeri revolved around staffing, training of healthcare workers, availability of specialized equipment, and incidences of fraud in the use of the National Health Insurance Card. In the Fisher story, Simon Theuri shared his story on how NHIF contributed to him accessing affordable dialysis services. His story mirrors that of thousands of others who have enjoyed NHIF services which are responsive to the needs of the people. Our position as a government is that a lack of finances should never bar anyone from being able to access healthcare, health services, or access treatment. On the question of affordable quality care, we rolled out free maternity services under the Linda Mama program and removed user fees in level 2 and level 3 facilities. We introduced health insurance subsidy programs and Edu Afya benefits package for learners in public schools. We also equipped 96 hospitals with modern diagnostic and managed equipment for specialized services in the country. In the past 9 years, we have nearly doubled the number of health workforce employed. Currently, we have over 75,000 healthcare workers in our payroll, and we continue to churn out healthcare workers from the 71 Kenya medical training colleges across 44 counties, not to mention the ones being trained in the private sector and the ones being trained in universities and other institutions of learning. So as we near our destination to achieving UHC, we must emphasize on prevention as opposed to curative care. And I think this is very, very, very important. The idea of prevention is what we must focus our minds about. And in that respect, we must worry about sanitation, we must worry about cleanliness, and we must remember that cleanliness is second to godliness, and prevention is better than cure.
As the population of Kenya grows, naturally, the number of people needing medical care is also growing. Our pool of available medical professionals and the number of the medical equipment has to grow to tandem with population growth. We may not be there yet, But no one can argue that we are not on the way there.
Well, you've heard what the people of Nyeri had to say about universal health coverage and the role that NHIF and MES play. You've also heard from the experts. Well, thank you so much, Mtala Mkosia, for the good job you've done. This has been Maishani Health, where we continue highlighting the progress and achievements of universal health coverage as envisioned in the government's Big Four agenda. Join us next week for yet another edition on the same. My name is Fred Ndimuli.
Kila siku wamama wako kwenye chama wakitafuta ya unga na pengine ya nyama. Afya ikiwa mambo iko sawa, lakini kuna siku yaweza kosa. NHIF iko, jisajili leo, kwani ujui kama kesho atakuwa maneno.
Maishani.